So we're glad that you're here today. And you know,
Wow.
it's interesting that this would normally be a work day from almost everybody. And because of what's going on in our country and around the world, there's not a lot of us are not at work now. And I think many of us know family, friends, relatives, loved ones, or somebody that has been impacted physically and a lot of us financially by the COVID-19 pandemic. So I thought the best thing to do as we start is just give 30 seconds of silence for those of you that just want to pause and think about it, maybe even say a prayer for those that you know. So we're going to start that at this point, and then we'll be back in just about 30 seconds. Amen. Thank you for that time together. I want to mention a couple of things to you that some of you may or may not know about. There is another webinar going on tomorrow at 8 o'clock Chicago time, 7 a.m. Eastern time. And this is the actual links. I'll be more than happy to send them to you. Our friend Bill Myers and a number of doctors from the Aravind Hospital in India will be presenting tomorrow morning. And so here's some of the subject matter that they'll be talking about and some of the different presenters that will be on at that time. I think the webinar will go for about 2 hours. A lot of different organizations sponsoring that webinar. So if you have time in the morning at 7 Eastern, 8 Central, and so forth, feel free to join us online at this time. It was interesting, I think Dr. Meyer and the Aravind Hospital had the same idea I did when we all were shut down by this pandemic, that we should try to do more and more things online. And so I was glad to get a hold of Dr. Gomez to be with us this morning. Another thing that you might want to be to know about is what Vision Outreach has recently been able to do. In years past, we took the Aravind manual, the MSICS manual that's in hard copy book, and we digitized it. But for a long time, the digitization was only for the Mac machines, the iPhones and iPads. And we recently figured out how to do this on a broader scale to where you can download it for Windows units and Apple units. And on your Apple, it'll take you straight to the iTunes store to download it. And most Apple devices have an e-reader already built in. And the Windows, a lot of them do not. So you can click at the bottom of the screen here. Well, where did that go? That took me to the wrong place. Hang on a second, we'll go right back. I want to show you how this works. I'm in PowerPoint now, so I'm going to end my PowerPoint for a second and show you how this works online real quick. So if you go to the website, and there it is, Vision Outreach, M6 Digital Book. There's the title of it there. If you go to the website here, and you come down, if you need to download an e-reader for your Windows machine, you can just click here and we'll give you 5 different free EPUB readers that you could download, and then you could download it onto your machine. If you prefer just to read it online, we now have a way that you can just click here and it gets you right into a file to where you can read it online, and you can thumb right through the pages by going to the right or the left. If you come to the bottom, you can click on this 9 squares and it will show you all the pages of the book down on the bottom. There's also embedded about 30 videos. So you can go to these pages and the different videos, and these will play for you online so that you can just see exactly what's going on. So we were glad that we were able to get this up and working for everybody. And so if you need the links to it, feel free to email me, and we'll be glad to send you the links to the brochure that we mentioned, to the M6 training book, and to the video link of this webinar once we're done with it. So those are just some of the resources that we have out there for you to use at your convenience. Well, Dr. Gomez is not a stranger to any of us. He's been doing cataract surgery for a number of years. He's been working with Vision Outreach almost 10 years, maybe 8 years, and his training of doctors there in the Dominican Republic. He's also the chief anterior segment in that department and cataract clinic of Ilia Santana Hospital. And I've known him for a number of years. I appreciate his heart and his desire to serve all people, especially the poor, and making it affordable for every person to have good sight. So we're going to take this time and just turn it over to Dr. Gomez and let him share with us at this time, and we'll go with it from there. Dr. Gomez, it's all yours.
Well, hello, everybody. I'm happy to have some of you out here. Roger, there, I got on my WhatsApp. Some people are trying to get in and they can't. So
I'll admit them all. Thank you very much.
I'll appreciate that because I spread the word around a little bit in my residency program. My fellows and some other people are trying to connect. So I appreciate that. Wow, there's a lot of people coming in now.
We just jumped up to about 30.
Yeah, that's great. Let me share my my screen here for a minute, then I'll get started. All right, can you see my screen there? Hello?
Yes, we can see your screen. Thank you, Carlos.
All right. Well, before I get started, I wanted to say this because I've been to a lot of webinars, especially these last days, and all the meetings that I go to. Every time I hear somebody talk about cataract surgery or refractive surgery or any procedure out there, it's like you're listening to God speaking. It's like saying, this is the way it should be done. Well, I'm totally against that. Sorry if somebody doesn't agree with me, but things can be done in many different ways. And what you're going to be seeing today is the way I do it, and it works for me. And I'm trying to share it so maybe a lot of people can use some of it or all of it and make it work for them as well. When we do cataract surgery, we have to realize that it all depends on whatever we have available at the moment when we do surgery. So that's part of the big thing. I have no disclosures. My only disclosure is that I trust God and I believe in God and I do everything that I do because of God. He sends me in places that I didn't even know existed. Didn't even know were on the map, but I get there and I do what He wants me to do, and that pleases me. So first, let's talk about the meaning of the procedure that I'm trying to express here. Why M6? At the beginning, when I first started hearing about it, I was already doing M6 and I didn't know it was called that way. I've been doing M6 since 1989, and my technique has been going through a process for many years, and I'm got to the point where I am right now. But it doesn't mean that's where it ends. Anyway, M6 stands for manual small incision cataract surgery. That's how everybody knows what M6 stands for. For me, I take it to a different level because when you talk about small and you see the incisions that we make, they're not that small. What it really is for me is that it's sutureless. So it's manual sutureless incision cataract surgery, and that's the way I look at it. Very rarely ever I put a suture in my incisions. Unless my incision is not perfect or I'm in a place where I'm not sure what's going to happen to the patients afterwards, post-ops, etc. I rather, if I can leave it sutureless, it's a lot easier and faster. So a few things about this technique that I'm using, advantages, the way I see it. Some of the advantages is that it's a technique that doesn't need high technology. Nowadays, when we do cataract surgery, and I'm a pro of technology, I do love technology, and I use it all the time when I have it available. But this technique does not need high technology. That's one thing that's why we use it a lot in the projects. The other thing is that you only need a few instruments. I use about 3 or 4 instruments when I do my incisions, when I do my surgery. And for the surgeon that's already a good cataract surgeon, has a short learning curve which means it's easy to learn. And this is my experience when I do the kind of Carlos projects here in the Dominican Republic. I bring surgeons and I teach them how to do this. I right away know which ones are going to be the ones that are going to be more advantage on this. The other thing is that it uses a lot less materials than when you do a phaco or other procedures. So that's a good thing. On the other hand, wait a minute. On the other hand, disadvantages that I see is that it's for people who are learning to do cataract surgery is not so easy. So for beginners, you need to have a lot of patience when you teach them. Their learning curve is a lot steeper than for experienced surgeons. And the other thing is that it depends on the blade. It depends on the crescent blade to do the incision. I have tried many different blades, and believe me, I tried everything out there because I sometimes do not have everything at hand. So one thing that I do realize is that it depends on a good crescent blade to do the right tunnel and build the incision properly. The other thing that is a disadvantage, in a sense, is that the anesthesia that we normally use when we do MSICS, I normally do use a retrobulbar block because I do have a lot of good experience with retrobulbar blocks. I've been doing it since 1985 when I started my residency program, and I'm really good at it. So I can trust what I do on anesthesia that way. But when I do MSICS in private practice, I don't use retrobulbar blocks very easily, unless it's a patient that does not understand what I'm going to be doing, or somebody who's really nervous or something, because I can do it on topical anesthesia, and I can do it with the help of an anesthesiologist with a little sedation. Normally when I do anesthesia, I use silicone gel, 2%, and I also use intraocular anesthesia as well. Well, the steps that I've included that we're going to be talking about, mostly we're going to be going through two of the main steps. We have the incision, capsulotomy, rhexis, whichever you want to make, and we're going to be talking about it a little bit more later. Lens rotation, for me, the way I do it is basically one of the most important things, so I can get the lens out of the bag and put it on top of the iris plane. The extraction, irradiation aspiration, and IOL implant. And I want to concentrate a little bit more today talking about the incision. When we construct the incision for an MSICS procedure, and I'm going to see if I can draw something here, we have to, let me see if I can, yeah, there we go. We have to make sure that we think about this right here. Obviously, this incision, the way you see it right now, it's an incision that's already properly open to the interior chamber, and it's something that's already been completely built. But basically, at the beginning, sorry, went over there. Basically, at the beginning, when you are trying to do this part here is the scleral tunnel that we built. And the way I think about it is that I'm going to build a scleral tunnel. It's going to be probably about halfway of the thickness of the sclera. And when I do the incision, and then I go from there on until I get to the cornea. And then I sort of put my blade towards the cornea and make a beveled incision, because when you have this area here covered with air at the end of the procedure, that lip of incision there, the cornea lip, is going to be automatically sealed, so you don't need a suture here to cover up for whatever you need. So that's one thing that's really important to me as I'm building the incision, that I make sure that this tunnel is properly made, so you can actually have a trustworthy incision that you can rely on during the surgery and after the surgery. So when you look at it and building the incision, this is probably the most important part here, is that you have to, the way I do it is I do a front incision. There's people that can make a straight incision over here, which is also good. And we're trying to avoid to do what we used to do when we do extra caps, is to go around the going circular as we go on the motion here. So what I mostly do is that I build this kind of incision here. It's a frown incision because it gets further away from the limbus here and here. So the closest point to the limbus would be this one right here, and it will actually cause a lot less astigmatism and be safer. Now, when you look in the corneal side, you'll see that in the corneal side, you have to have at least 1.5 to 1 millimeter thickness of cornea here, so you can have a perfectly secure incision. And I usually go all the way to here, and I try to build what I call a funnel incision, and you'll see it in a minute. So the motion when I use my crescent knife, I use, like if it was a center here, like a pivot center, and I sort of swivel around using the tip of the crescent knife to try to cut through the tissue and guide my incision and make it one step incision. So I don't make more than one step. One plain incision is what we want to do, and we want to make like a funnel incision here. And you'll see it in a minute in the next slide. So this is the thing. When you look at the construction of your incision, if you do a straight incision here, this is the limbus right here. This is the limbus right here. And you want to do a straight incision, you want to make sure that the closest point to the limbus is going to be at least 1.5, sometimes 2, but I think 1.5 to 1 millimeter is more than enough. And imagine I do an incision that's a front incision like that. I'm still in a safe spot right here. So then I go into the cornea and I go 1 to 1.5 millimeters and build a funnel type of shape incision just to make sure that I can have any nucleus that can go in there, can go through that incision and out of the eye. So when we look at it, and we want to build this, we want to make sure that we build it properly, so we don't have the incision that it would be then bad for us. Mind you, when you construct your incision properly, the way I teach it to my residents is that I tell them that if you build the incision right, the rest of the procedure is going to be a lot safer and a lot easier for them to do. So I make them concentrate on building this properly so they can have a safer incision, safer procedure that they can rely on. I'm going to show you how I do my video, how I build my incision. You're going to see just exactly what I mean on these explanations on a video, so you can see that I'm actually doing exactly what I say. And if there you go. Can you guys can you tell me if you can see the video there?
We can see it, Carlos. Thanks.
Great. So you can see I do a kind of a front incision, and I go about 1.5 millimeters. I build my tunnel. I never go in to the eye, never go through the tunnel until the very specific time. But I build my incision, and you can see that the crescent knife is perfect for this. Once I build the tunnel, I have gone through the capsulotomy or capsule rexis. Then I use a phaco knife to go through the tunnel. If you can see, the tip of the knife never goes into the tunnel. It never comes out of the tunnel. It always stays in there. So I can actually make sure that I'm making a one plane incision and build a perfect tunnel. Now, say we have an incision already built and we want to go and get this nucleus out of there. The way I do it, and I'm going to show you, this are pictures that I was able to find. I normally rotate the lens. Sorry, let me get back here. Whoa, what's going on? Ooh. Okay. So basically, I try to rotate the nucleus always thinking that I have a pivot center, imaginary pivot center of the nucleus, and I actually try to make a vector force going into the eye and around, and that could be clockwise or counterclockwise. It could be both ways. Sometimes when I'm trying to rotate the nucleus, I go one way first and then I go the other way to make sure that I sort of feel that it releases the posterior capsule, and I can put some pressure in there and rotate slowly, making sure that this area here that you see comes out of the capsule and goes on top of the iris over there. And once I get that, then I can keep rotating like I see in figure A, and I can keep bringing this side of the equator up on top of the iris there until I can get it all out. Now, somebody was asking me earlier if I prefer to do capsulotomy or capsulorhexis. It doesn't really matter. The one thing that you have to make sure if you do capsulotomy is that your capsulotomy has to be big enough depending on the nucleus that you're going to be doing. And let me see if I can get to, all right. There you go. All right. So let me see if I can get to sort of give you an idea how I do it. Say this is the nucleus right here, and I want to do a capsulotomy. It doesn't have to be too big if it's a capsulotomy, because a capsulotomy will release pressure on either point, and it will help you sort of let it go. It doesn't matter how big the nucleus is. So I try to make a small cuts, and this is not so small, but I make like little cuts with a cystotome, and I try to meet from one place that it's not cut to it's like creating a dotted line, and I go all the way around until I have a capsulotomy. Now it could be about, say, 4.5, 5 millimeters. Once you start rotating this nucleus, this capsulotomy will seed and will let go the nucleus once you get this area through the capsulotomy. Now, if you do a capsulorhexis, that's a different thing, because a capsulorhexis will need to be a little bit bigger than this. You have to make it bigger, something that's closer to the iris, say about 5.5 millimeters, 6 millimeters, just to make sure that this nucleus comes out through the capsulorhexis. If your capsulorhexis is too small, then you end up having to do relaxing incisions, depending probably in the 4 quadrants, just to release some of the pressure here so you can bring the nucleus out through there. Now, the way I see it, like here, you can see back here, there's a capsulorhexis there. I'm tending to do more capsulorhexis as I've been doing this more and more. But when I have really dark nucleuses, it's like I rather don't even try capsulorhexis. I do a capsulotomy because sometimes you don't see much of the capsule, even if you use some of that staining blue thing, but you want to make sure that the capsule is going to let that big nucleus out of there. And the only way I can make sure that is if I do a capsulotomy. Now, to do a capsulorhexis, I've gotten to the point where I was not being able to use the utratus for my phacos, because the incision in the phaco was 1.2, 1.8, 2.2, and sometimes you introduce the utratus through it, and when you open it up to try to grab the little far end capsule, it will hold the capsule and it will hold on the incision, and it will let you go through it very easily. So I got frustrated, and I got a lot of complications through that. And since I was very experienced on using the cystotome, I started doing my capsulorhexis with a cystotome, and I completed any size capsulorhexis that I wanted. So I can go through the side ports, the paracentesis, and do my capsulorhexis or capsulotomies, whichever way I wanted. But a few years ago, I came across this beautiful instrument that I saw on a video one day, and it's called a micro-utratus. And the micro-utratus can go through a 1 millimeter incision on the paracentesis or the side incisions, and you can do a capsulorhexis through there perfectly. So I started using that more, and I finally got to the point where I can say that I can use the can do capsulorhexis with a Utratus, but it has to be the micro-Utratus for me. Now, that could be different for everybody. Another thing that people can do is if you go through the tunnel that's not been opened yet and use the phaco knife and you go through the tunnel, do just a stab incision. You can use your normal Utratus and do a capsulorhexis through there. But I don't know, it's like too many wounds going at the same time, so I decided to do it differently. And I use more the capsulotomy needle, the cystotome, or the micro-Utratus, which works great for me. But you can do, what's more comfortable for you. The way I put it is that, it doesn't matter how you do it. What matters is what you do and how it's at the end. How well it's done at the end. My mentor, Dr. Juan Valle, when he was teaching me cataract surgery when I was a resident, he says, I don't care if you do it with a spoon, but as long as it comes out with a round pupil and a nice round air bubble in the middle of the anterior chamber, then you're doing it right. So I got the idea that, at the beginning when I started doing cataract surgery, we didn't have all these crescent knives and phaco knives and all that. We only have 65 blades that were used for normal general surgery, or a blade breaker, which was even harder to work with. But I used whatever I got my hands on because at the hospital, we didn't have much. We had donations, and whatever came in the donations is what we used. So I got used to doing different things. And that's how I got to the point where I try to work it out with whatever I have available. What scope I have, doesn't matter. I'm used to whatever I have, and Roger knows. He's been with me on projects, and it's a thing that you have to adapt. It's like Navy SEALs. They adapt, they overcome, they improvise. It's same thing with cataract surgery. We have to adapt to whatever situation. It's the same thing that I do when I'm doing a phaco and I have to convert to extracap. What do? I use the same incision because I know how to handle it perfectly, and I don't have to have, like normally people in extracaps, they put this eyeball to soften the eye. I don't do that. So I'm pretty used to the sclera the way it is, and I can handle that with no problem. Now, if we look at the rotation that we were talking, going back to the subject, let me show you a little video on how I rotate. And this is a video I put together a few years ago. And it's like 3 videos on a roll showing 3 different kinds of cataracts. And it's rotating the cataracts exactly the same way in every case. So this is a cataract that we normally find in our practice here in the DR. See how I rotate it? I make a force that's rotational, but it's slowly and continuous. It's not bit by bit. You have to put the force of rotation and keep moving it and keep moving that instrument that you're using to rotate your nucleus until you're completely sure that it's rotating in the anterior chamber. It is another case. It's a harder cataract, and I tried to do a capsulorhexis, and it came out to do an Argentinian flag, but still, see that? I'm moving my nucleus exactly the same way and always bringing it out to the interior chamber. And once I'm there, I'm trying to make sure that it's rotating and there's nothing attached to it. And here's the harder case. This is a smaller pupil, totally black lens, and I did a capsulotomy right around the pupil's diameter, and I'm trying to loosen up this nucleus a little bit until I can see it moving a little bit, and then I do the same motion. I rotate, pushing down and around firmly and continuously, just to make sure that this nucleus is going to rotate through there. So in rotating the nucleus, that's what I do. I wanted to show you a few of the things that I've gotten out. This one right here, let me show you this one. What you see here, this is looking at a nucleus sideways. This is not the front of it. This is see how thick this thing is. This is some of the nucleus that I've gotten out, and I sort of have a collection of these nucleuses in pictures, of course, just for the fun of it, just to remember what I do and how I do it. And a few things that I wanted to say. Let me show you a couple of post-op day. This is how most of my eyes look the next day, and you can see, they pretty much look at if I did a fake one, but they actually have, as you can see in the top side here, they actually have the area of the incision. You can see it there. You can see the area of incision here, right here. It's a little red, and it's just the first day. This incision is sutureless. I have no sutures, and still being able to maintain the anterior chamber through the post-op time and over the years. I have had very little, very few cases where, due to trauma or patient sleeping on the eye, the incision opens up and end up being having iris through that incision. Because this incision, let me show you again. This area of the incision right here, it's very beveled. So the iris is further back here. For the iris to come out through the incision, you have to apply a big amount of pressure to get that iris through there. And that's very uncommon to do. Even the patients that I do on projects, we give them instructions all the time. And if I see a patient that I can doubt for a minute that they could harm their eyes, I'd put a suture there with without thinking it twice. Normally, I have a bubble that it's on this area here, and I don't normally do a full chamber bubble. I do about 75% bubble, because when this patient stands up, this bubble is going to go all over this area and push and seal the incision over there. So, sorry, that's pretty much what I wanted to show you. I wanted to just basically go through those two steps, because I found teaching people that these are the most critical parts of the surgery. As for the irrigation, aspiration, and all that, it's easy. You can use a Simcoe cannula or bimanual irrigation aspiration if you have available, whatever you can get your hands on. Let me tell you this. This is something that I teach my residents all the time when I'm teaching MSICS. Before even I go into the OR with them, I teach them how important this is. For me, preserve the tissue and restore the vision is the main reason why I do this kind of cataract surgery. I've seen people do cataract surgery to literally destroy an eye trying to get a cataract out. Not all cataracts are treated the same way. For me, every cataract, every eye is a whole different world. And by thinking that, it's the only way that I can, by thinking about this, it's the only way that I can preserve the tissue and restore the vision. Something else that I teach my residents is, it's not about being the best. It's about being better than you were yesterday. So it's about being better all the time. One thing that I tell them all the time is that, the day I stop learning, I'm going to lose the passion for what I do. And when I do that, I'm going to quit doing surgery. That's, you can be sure of that. So every day I go into surgery, I'm the happiest guy because I love being in surgery. But, being in surgery does not mean you're a good technician doing an incision and taking the cataract out. You are somebody who's aware of the tissue you're dealing with, the patient you're dealing with, and what you're trying to accomplish is to restore the vision of that patient. Thank you very much, and I'm going to take my screen off if there's any questions that I can do.
Thank you, Dr. Gomez. We do have a question in the chat box. I believe there's an opportunity that you can raise your hands if you want to ask a question. Somebody will have to tell us where that's found, because I was looking for it earlier and couldn't find it. But we do have one question from Nathan Stevens here. It says, let me see if I can find it. Can you go over how you deliver the nucleus after you get it into the anterior chamber? That is the step I have struggled with the most. So if you could go over that, that would be great.
Sure. The one thing that I when I was learning to do cataract surgery, we were doing only extra caps. And the way we were doing is once we got the capsulotomy done, we were expressing the nucleus. We were putting a lot of pressure at 12 o'clock exact time on the opposite side of the incision, putting pressure there and pressure on the wound and getting the nucleus out. Well, it was like, I believe, if I'm correct, it was probably when I was in my second year. We were having rounds one day, and somebody brought this video that was made by this Japanese and people. They put a little camera through an eye from the bottom, looking at, like if you're looking at the ceiling up there was the nucleus, and he showed what happened when you express the nucleus, the amount of pressure, and what happened to the ora serrata over there. I just got shocked. I mean, I went into panic that same moment. And right the next day, we switched from expressing the nucleus to trying to put it up on the anterior chamber and go in fishing it with a lens loop. Back in the days, we didn't have viscoelastic. We're using only air. So the lens loop was, it was we have to be very careful not to break the posterior capsule. But once we got our hands into viscoelastic, that was a lot easier because what I do normally is that I rotate my nucleus and put it in the anterior chamber, and then I put a bed of viscoelastic underneath it so I can get my lens loop underneath there and bring it out, and I fish it out that way. And I have no regrets in doing that because it's pretty safe. I don't remember breaking a posterior capsule that way since I had started doing it using the viscoelastic to create that space between the nucleus and the posterior capsule.
Thank you, Carlos. We do have another question from an individual from Africa. The question is, do you make a temporal incision or a superior incision, and which is preferable?
Yeah, I've had to do both. I'm a little bit concerned about doing a temporal incision and this kind of incision because you have no protection on the side. There's no bone over there. And when I have to do that because, say, they ask me to do, like, we get this really bad cataracts, and then surgeons at the glaucoma department ask me to do the cataract first, so then they can do the trabeculectomy later. They ask me if I can save the superior area for them to do the trabeculectomy, so I go temporal. But what I do is when I go temporal, I make sure I put a suture on it. I'd rather do superiorly because you have protection there. There's the bone, face bone there that could protect from injuries and protect even if you're trying to, if you lean on it or rest on top of your eye. But it could be done either way. I have to do it many times. I have to do it temporarily because different times. Also, sometimes you have people with very deep, short orbits, and working superiorly, it makes it really difficult for me to do an incision like that, and even more to get the nucleus out of there. So I go temporally, but then I make sure you put a suture on it.
Great, thank you, Dr. Gomez. Are there other questions? I'm looking for hands or comments. If you've got one, I've got one here. Let's see. Who makes a micro-utrata that you use?
Just about everybody out there, but I'll tell you, I hate to say this because I don't want to get into that, but I came across a micro-utrata about 4 years ago when I decided to start using it. I've seen videos of people using micro-utratas. And I was in a meeting. I don't remember if it was EACRS or the Pan American Ophthalmology Association meeting or somewhere. It was a big meeting. And I was walking around with the people that sell instruments, and I came across these Chinese people that had this micro-utratas, and I looked under the scope, and I looked at them, and it took me a little bit to decide if I wanted to buy them or not, but they were so cheap. They only cost me like $70 or something. So I decided to buy them and take them home and see if they work, because I thought, because I figure, I went around and I've seen it, In other places, it costs $500, $300. And I didn't want to go and spend that much money to just try something, see if it works. So what I did is I bought this really cheap instrument, and I came back and I started using it. And it was just mind-boggling. It just changed the way I did capsulorhexis forever. So I thought, when I go to the next meeting, maybe I'll buy a few more of these because, you know, it's a Chinese thing. It's only $70. No racism over there, but, you know, sometimes you buy instruments from so many vendors and they're not really good. And I thought, well, I tried it, only $70, you know, it's not that much. I'm going to buy a few more just to keep them in my stock just in case. And I even thought of buying, you know, the real expensive ones. But then I thought, you know, different people handle my instruments, and I don't want to have my instrument go overboard just because somebody didn't know how to deal with them. So I bought like 3 more, which I still have in my closet, because that little inexpensive Chinese little forceps has not gone bad yet. So I've been using it for 4 years and still running. So, you know, if you want to try it, if you go to a meeting or you can order from somebody, always try something cheap to see if it works and you can handle it. And then if you want to go into something else, I know MSICS sells them. I know, and I don't want to be the advice person for anybody, but MSICS sells them, and I know some of the people out there that big brands can sell them too.
Great. Several more questions here from Michael Posner. Says, can you please share your thoughts about above questions regarding potential posterior capsule defect?
I'm not sure I understand about posterior capsule defect. If you mean rupture.
I'm sorry, let me see if I said that correctly. Hang on.
I'm reading the question here.
I might be able to also help because I had a similar question. Bill Myers from Chicago.
Go ahead, Bill.
Okay.
I've been taught that if you can't see the posterior capsule through the lens, that you should assume that the capsule may not be intact due to posterior polar cataract or post-trauma with significant zonular damage, or due to dense adhesions of the black nucleus to the posterior capsule. And I worry in your technique of pushing down on the pole of the lens to get the other one to pop up, that could lead to trouble in some cases. What's been your experience with that?
Great question, and I'd be very happy to answer that. My experience with that is that in the cases that I do MSICS, I don't ever see the posterior capsule. Normally, when I do projects, it's projects of people like here in the hospital. Most of these people live out in the country, up in the mountains and places far away. They bring them in a bus, and after they've been seen, we check them out. When you look through the scope, very rarely ever I see a red reflex on those patients. So most of these patients, I don't see the posterior capsule. What I've learned to do over the years is that I've learned that I never do hydrodissection on a dark lens. Never, ever. I learned to do cataract surgery by rotating the nucleus all the time. Back in the days, we didn't know about hydrodissection. And very rarely ever we broke that posterior capsule unless we were going very fast and being very aggressive. So the way I put it is, the way you saw in the video, is that I go very gently, but I go firmly and slowly rotating that lens just to feel it, and you can actually feel it releasing from the posterior capsule. I don't ever do hydrodissection on a dark lens, because I tried that when I started doing phaco, and I got so many more cases of posterior capsule rupture than I could possibly even handle. So I then went back to my mind. I said, but wait a minute. Every time I was rotating a nucleus, when I learned to do extra caps, I was able to rotate it with no defect on the posterior capsule. So let me go back into that. So I started doing that again. Very rarely I have a posterior capsule break. It has to be one of those very, very incredibly dark lenses that's very attached to the posterior capsule. And I still work it around that. I go one side and then another one, a little bit, sort of making sure that it's loosened up as I go sideways. And when I feel it's loosening up, then I do the motion of rotating completely. But it's a motion, like I said, and I teach my residents, you can't go like fast or you can go too slow. You have to go slow and firm until you get it done. That's the way I learned to do it. And it works for me that way. There's other techniques that I've seen people using a pre-fracture instrument from Akahoshi and go into the nucleus and open it up in two parts and then hydrodissect. It takes a little bit more work than you can possibly see it on a video. But, you know, I try to go safer, and the safer that I can do it is that way. I think for me, it's worked so much better. And the way I teach my residents and people that are coming to learn with me is to do it that way. And I really haven't had any real problems teaching it and people learning it once they see me do it on the scope.
Great. Thank you. Several more questions here. When would you advise to choose capsulotomy over continuous capsulorhexis on MSICS?
Yeah, I said it before. I tend to do more capsulotomies when I have a very dark lens, because even if you try to stain the capsule with vision blue, sometimes you don't see the capsule very much. Even though, as long as I can see the capsule, the anterior capsule, I do a capsulotomy. But I make sure that capsulorhexis. But I make sure that capsulorhexis is big enough to get that nucleus out. If you dilate your pupil and you can see that you have a big lens, you might want to, if you want to do capsulorhexis, you might want to do a big capsulorhexis. You don't want to do small capsulorhexis because you don't want to rip the capsule by trying to bring the nucleus out. So in some of those dark nucleus lenses, like the ones I showed on the screen before, most of the time I'd rather do a capsulotomy, because the capsulotomy has many points that when you put the pressure on it, all those points were sort of spread the tension around and not rip the capsule. I say if you have one perfect capsulorhexis that's too small, and you try to bring the nucleus out, somewhere along the way, that capsule is going to tear out and go all the way out, and maybe possibly go all the way past the zonules, and then you have a problem. So I try to avoid problems, and the way I've learned to do it is to do capsulotomy when I have dark lenses as much as I can.
Great. Next question. What has been your experience with combined cataract and trabeculectomy surgery versus separate surgeries, and what have been the outcomes?
I never do them at the same time. My experience in doing it, I don't do a lot of glaucoma, but when I have to do trabeculectomy, I never do it at the same time, because I find that the incision that I make, the reaction, the inflammatory reaction, can close the wound on the trabeculectomy a lot faster than normally. So what I do is I go 2 steps. I go 1 step, I do the cataract first, then check if I really need a trabeculectomy, because that's the other problem. When you have dark lenses and you're trying to control pressure, every time you bring the lens out, your anterior chamber will grow up and become bigger, and then your angle will open up a bit. So before I decide to do a trabeculectomy, when I try to do an M6, I do M6 first, let it sit for a while, check on the patient, and see if I really need a trabeculectomy later on. If I do need it, then that's the kind of patients that I'd rather do the temporal incision on the M6 and then save the superior incision for the trabeculectomy. But I never do them at the same time. My experience is every time I did it, the trabeculectomy wound will close and stop working.
Great. I think there's one more question there about the retrobulbar injection and your confidence in doing that. You like to address that?
Sure. Um, nowadays, one of the things that have been lost in teaching in all around the world, that as far as I can see, is that retrobulbar injections are it's like a terror. I'm going in with the needle and I don't see how far I am, where I am, and I agree with that. But since I learned to do blocks with retrobulbar, I became very confident, and I learned to use the same needles all the time. And also, I learned to see how far the needle is when I do the retrobulbar, the places of injection, the direction that I give my needle, and it works. And my residents here at the hospital, and some of them are already here listening to this lecture, and they know what I'm talking about. When they see me do retrobulbar, they don't believe it. Once I start injecting, you see the upper lid going down right away because I'm in the proper place, right behind the cone. So retrobulbar injections could be great for somebody who learns how to do them with somebody teaching them there next to them for a while until they can actually handle a lot. I don't use other injections because I never learned to do other things. But retrobulbars for me, they work, and I make sure when I go on a project or when I'm doing surgery that I have everything I need. And one of those things that I need is the syringe and the needle that I use for retrobulbar every time I use it. In my OR, there's always retrobulbar needles just in case, because you never know when a patient's going to need one. And I've had cases when I go in with my mind set up of doing an MSICS supported only on a topical anesthesia, and I ended up changing what I was doing, doing a retrobulbar just because I want to make sure that the eye is not moving, that the patient is not feeling anything, and that everything comes out right.
Great. One more question before we start wrapping things up here, or maybe one, maybe two. How do you deal with broken capsule, descending lenses, and vitreous prolapse?
Dear Lord, any which way I can. It depends what I have, where I am, what I have available. Mind you, I've been in places and circumstances where I wish I'd never got into because I didn't have everything that I needed. But you know when you go on a project all the way around the world to places where you didn't even know existed, you won't have all the materials and all the instruments and all the machinery and all the scopes and all the nurses that you probably would need to have and do a perfect case. So you go and improvise. I remember when I was learning to do cataract surgery at the hospital, we didn't have a vitrectomy machine. There was none. So we learned to do vitrectomy with wax cells. Do not do that anymore, please. Try to have any kind of source of vitrectomy when you're doing cataract surgery. I would highly recommend that. But if it all comes to whatever you have, if my capsule breaks, I try to lose as less vitreous as I can, and to save enough capsule to do a capsular lens supported lens, to try to keep the lens in one place. But if worse comes to worse and you don't have the proper things, and then you sometimes you have to leave the eye without an eye intraocular lens. I've been through that, and I know it hurts like crazy. Every time that happened to me before, it's just mind-boggling. It's like, I don't want to go home. I don't want to have dinner. It's like a patient died on me. It's that bad for me. Losing vitreous is not an easy thing for somebody who is trying to do the best that can be done. And for me, every eye that I operate on, I have to do the best it can be done. So losing vitreous is not in my mind. It's not an option. I have to make sure that I do every right step, every right movement, use the instruments that I can use to avoid losing vitreous or have iris prolapse. Iris prolapse depends so much on the wound that you make. So making the incisions properly, paying attention to that step that you're doing is the way I tell my residents. I tell them the first step you do will make sure that the second step will be good or bad. So I pay all my attention to do my incision just to make sure that it's properly made. I don't, people think I operate and I'm a fast surgeon. I'm not. I'm very slow. They see me start a case and finish very quickly because I'm going very slow, and I'm making sure that every step that I make, every step that I do is perfect, so the next step is not a complication. So trying to avoid those complications would avoid iris prolapse, vitreous loss, and all that kind of stuff that happens. If it does happen, I've been in situations where iris prolapse is a problem, and I try to tuck it back in and suture that incision, and maybe do something else on the sides or go somewhere else for the incision.
All right, last question before we start letting people go here. And thank you everyone for your attendance and your patience. Just a question about peribulbar versus retrobulbar, and have you done peribulbar before?
I have. Like I said, I'm not very good at it. I never learned to do peribulbar in my training, and I've seen him do it, and it works for a lot of people. My advice is to do whatever you feel comfortable with. I feel comfortable with retrobulbar more than peribulbar. So if you feel better with peribulbar, it's probably safer to do that. And I agree to somebody who can do that and be safe. I do not agree with people that are trying to do things that they saw on a video because they saw and it looked easy to be done without any training or somebody there who can talk them how to do it or teach them how to do it, because it's dangerous unless you're a very experienced surgeon. It's like they say in the movies, don't try this at home.
Carlos, can you hear me?
Turn up your mic just a little bit, Dr. Pletcher.
Alrighty. Hey, Stan. Good to see you, man.
Good to see you.
Good to see you, brother.
Can you hear me now?
Much better, thank you.
Okay. What I was going to say is I really had not had any experience with peribulbar until this year. And my tech, who had been with someone else, said, you need to try this peribulbar. And it's the Connor cannula is what we used. And it was fabulous. I was really impressed with it. We switched completely to it, and the safety is much better than retrobulbar, and the speed was much better. We didn't have to wait for the cone and balloon and all that. And so what we did is we made, gave topical, and then the first thing I did was make a little snip at the infranasal conjunctiva, just a few millimeters back. And this Connor cannula just kind of slides around the globe, and you kind of feel getting right behind the equator. And we put in three cc's, and the patients had very good motility blockage. I mean, the eye was relatively ophthalmoplegic, and good pain management as well. So I found it to be very easy to convert to. And I'm pretty hesitant to do new things when something's working for you, but we switched to that and didn't look back.
Great. I'd be more than willing to try that. I haven't had the luck. See, here, I don't let anybody do my blocks. I do my own blocks because I trust what I do. But switching to peribulbar would not be a problem if I have somebody who can be there with me at the beginning and show me through the steps and having the right cannula to do it either. Sometimes it's a problem of not having the proper cannula or needle to do either retrobulbar or peribulbar. And I agree with you. If it's a lot safer that way.
Stan, who makes the Connor cannula? And I always called that block a peribulbar block, and then a peribulbar. The way I did it was with a needle, both superior nasal and inferior temporal. That works a lot better if you've got wide ace.
Yeah, wide ace would be nice, but yeah, this is subtenons. And whether it's peribulbar or peribulbar, Stores makes the cannula. We didn't actually have that one. We found some that looked pretty similar, and it worked. I mean, I would love to have the Stores. I think the Stores one's pretty expensive, so I imagine looking at some of the Indian-made cannulas would probably be a good idea for if you're getting a bunch of them.
And Bill Myers here. At Aravind in the last year, they switched entirely from retrobulbar to what they call subtenon's block, which is, I think, what you described. I think a parabulbar is a needle through the lids, but not pointed into the cone, and subtenons being snipped down through conj and tenons, so you don't get ballooning of the conj, and then put in the 3 cc's into the subtenon space, which goes all the way around the globe up to the optic nerve and gives very good akinesia and anesthesia very quickly, as you described. And one can use the old style reusable BSS cannula that you put on the little BSS bottle, and that has the right curvature to slip behind the globe through that tenon snip.
It was interesting because there were times where you put it in and you just felt like it was just at the right spot, and there was not much tension to putting it in. And there were other times where you kind of you felt like it wasn't wanting to go. You repositioned the tip and then it went. So there must be some space back there that you can get into that made it easy to get to put it in.
Probably some septae there.
Yeah. I was going to say also, when I do retrobulbar blocks, I was taught at the beginning of my training, just a few years back, that you do retrobulbar blocks, and it was like 8 cc's of anesthesia mixed half and half, xylocaine, marcaine, and then you inject the whole thing back there. And that, even back then, that looked very gross to me. It was like, whoa, this much. The eye would bulge out, and you get all this bulgy conjunctiva. So I started changing my things around, looking for other ways to do it. I even came to the point where I was using carbocaine from the dentist with a carpular, and I was using that. And with only 3 cc's, I got all the akinesia that I needed, and the patient would not feel anything. The eye would not get red, no bulgy conjunctiva, no nothing. But then it was kind of hard to come out to the patient and use this carpular and put this cartridge in there and try to go in there, and the patient would look at it, wait, what are you doing? It's like they remember the dentist all the time. So I switched back to the other way of doing it, but I used a lot less. I used no more than 4 cc's, and I basically inject 3 cc's down there, and I put half a cc on top of on the superior lid. So these eyes are not squeezing at all. They don't feel anything, and it works. Now that you mentioned the peribulbar, and I've seen it, it works, and I think it's a lot safer. I'm going to try to get some of those cannulas and see if I can switch, because definitely, you know, I'm always looking for a better way of doing things. It's the way I said at the beginning. The day I stop learning, I'm going to lose the passion for what I do. So I don't want to lose that. I want to keep that until the end of my life. And the way to do it is to always keep learning new things. And I'm always looking at other people doing surgery. I tell my residents, I learn even from them learning how to do surgery. So sometimes I come across this new little thing that I say, that could work. And I'm going to try and see if it's better. Or maybe I say, no, that's not really good at it, or something too dangerous. I'm trying to avoid dangerous things all the time. So when I teach my residents and my fellows, I tell them all the time, listen, let's play it as safe as it can be. And that's one way of doing it. One thing about retrobulbars is that, like I said, I do my own retrobulbars. Very rarely I have my residents do my retrobulbars, because I know what I'm doing and I'm very confident with it, and it works. So I agree with you, Stan. I should try for another way of doing it safer.
I'll mention one disadvantage and one advantage. One advantage of the peribulbar that you might not even think about is at the end of the case, if you do subcons or subtenons, dexamethasone or any antibiotic, I was able just to slip it right into that, and the patient never felt that, as opposed to taking a 30 gauge and hitting the nasal conjunctiva. They almost always feel that at the end of the case when you do a retrobulbar. The disadvantage, the one patient that we gave a retrobulbar on was pretty inophthalmic, and so the retrobulbar does a better job of bringing the eye forward. Maybe I didn't just put enough volume, but I looked at the patient and I said, no, we need a retrobulbar on this one. So we did a retrobulbar just to bring the eye forward more. I
see. Yeah, it's true. In terms of using antibiotics, I do intracameral all the time. I've been doing it for a number of years. We even did a study at the hospital and showed that it was a lot better to do intracameral than do peribulbar injection of whatever. Right now, I'm working on a study doing a mixture of moxifloxacin and what is it? Forgot. The Trimox, use Trimox, and we're doing it intravitreal through going through the zonules. So far, it's the best thing I've been able to see. These patients don't need drops. They don't go home with drops. We don't have to worry about giving them drops and make sure that they use it or contaminate it or just throw them away. Or, sometimes we've had, like, we go on a project and we give people drops and everything, and they come back and it's like, their eyes is inflamed, or you have some other kinds of problems. And it's because they haven't used the drops properly, or they lost the drops and they didn't care. So one thing that I'm working on is try to see if I can get these patients to get on antibiotics that work and they can go home without worrying about the drops. You tell them using every 2 hours and they use it twice a day. It's not enough. So the patients that we've done it, the study it's ongoing right now, but we sort of review it, and out of the 20-some patients that we did, all of them are great. None of them needed anything else.
Have you done this with MSICS patients or only with phaco patients?
We've done it only with phaco patients so far, and the idea is if it works with phaco patients, then we're going to try it in M6 patients. A friend of mine from Florida is the one, he's been doing it for 5 years now, and he's giving me the data, and it's just mind-boggling to see that all of these patients are doing great.
No topical.
No topical. No.
Carlos, was that Imprimis or was it another formulation?
We mix it ourselves. We try to use stuff that we can get here and make our own mix, and we do it in the OR properly with all the proper sterile area and all that, just to make sure. I'll tell you, at the beginning, I was really, should we do this or not? Or, this friend of mine tells me he's been doing it for 5 years. And, it's one of those things that, you can hear somebody say, this works, but you don't see the data. It's like, should I trust this or not? Then I talked to him and he showed me the data, and he says, yeah, listen, man, I've been doing this for 5 years. This is the data. And he showed me, and I said, I can't believe this. So I was kind of willing to try it, and we sort of started the study a few months ago. We've done 20-some patients. Obviously, there's patients that you don't want to be getting to that at the beginning of the study, just to make sure that the study is properly made. And then once we get the results over a year, then we might be able to switch to do it on M6 patients and see how it works. If it works, I'll tell you what, I'm going to be switching to something that I can rely on, that I can have my patients properly taken care of and making sure that they don't have any problems back home.
Yeah, I work with Neil Shorstein, and what we recommend is intracameral moxifloxacin or whatever one you want to use, and then put in subconjunctival steroids. So if you had to remove it, you could just snip it out. That way you're not putting it in the vitreous where if you run into trouble, it's tube or vitrectomy.
Yeah, well, we haven't had any troubles with people putting it in the vitreous. I switched to do moxifloxacin and dexamethasone about 12 years ago.
Yeah.
I went to a meeting in Guayaquil, Ecuador. A friend of mine was using it. He had already been using it for over a year, and he showed the data on that. And I was thrilled. So I went over to the Alcon representative here and asked them for that medication. It's a mix. I don't know if they have it in the States. It's moxifloxacin and dexamethasone. Here it's called Vigadexa. And so I got some of that, but now I don't use the Vigadex. I only use the moxifloxacin, which is the Vigamox, and I give them steroid drops to take home most normally. But looking at the data on this new way of doing it, the only thing is that you have to make sure the patient understands that the next day it's not going to be a 20/20 vision, because you're going to have a blurry vision for 24 hours or so. But then after that, all of our patients came up to their best visual acuity as anybody at the end of the thrill.
Well, thank
Was
you.
that triamcinolone or dexamethasone intravitreal?
We use moxifloxacin and triamcinolone.
Okay, because that's why you get the blurred vision is the crystal.
Yeah,
Okay.
that's right. That's what.
Dex wouldn't do that.
Right, that's right. But we don't want to put Dex in there yet. You know, I haven't seen any study that supports it that I can really rely on. But this study on this guy, you know, it's really blew my mind. And I
So
tried
who is
to.
that again? Who is that, doctor?
It's a friend from Florida. His name is. This quarantine got me thinking about it the wrong way, but his name is Barber, Dr. Barber
Kevin.
from Florida.
Dr. Kevin Barber.
Yeah,
So I
Kevin
just
Barber.
wanted-
That's right.
Kevin
I'm gonna jump
Barber.
in.
Okay, I know.
Thank you, Dr. Carlos, for all of your information, for your presentation, for the answer to the questions. Glad that you are with us today. Let me remind each of you, if you haven't looked in your chat box, try to look over there. There's a lot of resources that different individuals and we put over there for you. If you don't know how to get in and get your chat stuff in those resources, just email me at roger@visionoutreach.org. And we'll be glad to send you some of those resources. Again, thank you so much for being here. We're going to sign off. And if you'd like to get a link to the video in this webinar for future use, let us know. Send me an email, roger@visionoutreach.org, and we'll make sure that we get you to that. God bless you.
Thank
Guys
you,
stay
Roger.
safe and have a wonderful rest of your week.
Thank you, Roger, for putting this together, and thank you everyone for being here. Hope I was helpful in some ways for you guys. And you can contact me anytime. You can go through Roger, and he can give you my email address and everything. Thank you
That's
very
great.
much.
Thanks again to everyone for joining us. Have a great day.